Respected chairpersons and dear friends, at the outset, let me thank Dr. Jay Shah and the team ACS 2025 for having invited me to deliver this lecture here. Well, this is an area which is very close to my heart, and I'm very passionate about this. So I think the topic that has been given to me is basically look at how newer strategies, all of us have been hearing this. Now, heart failure, the moment you diagnose this, it's important to understand that this is worse than acute coronary syndrome. Look at the bar on the left-hand side. Acute coronary syndrome, we categorize as many stages. For example, you have the lowest risk, where you try to do some primary prevention. But as you go higher up, based on the risk factors and whether you had an event or so, you have various kinds of risk stratification for acute coronary syndrome. But when you talk about heart failure, and that's what the problem that we really face in the country these days, once they have a heart failure itself, the stable so-called people, once you have somebody with an LV dysfunction and you diagnose them having a stable heart failure, that is no longer in the lower risk. It's actually, they fall into the higher risk category. And the kind of patients which Dr. Jayshaw was alluding to, the worsening group, and they are the very extreme high risk patients. So there is nothing like a stable heart failure is what you need to understand. And when we look at our own data, this is what I'm not really going to scare you, but then these are all the facts that has evolved over the country in the last few years. We have had three major registries. I've been fortunate enough to conduct a large registry in this country in the last 5 years. We did more than 10,000 patients in the Indian College of Cardiology registry. What you see on the right-hand side is the ICMR promoted the National Heart Failure Registry, and this is the Kerala component of it, which came back. All these things. Now, if you look at it, the major problem today is ischemic heart disease. And then we also need to understand here that why are we talking about this as a physician? Because these are patients with a lot of comorbidities like hypertension and diabetes in at least about one half of these patients. So it's important to understand this. And what is even more important, we have relatively younger patients and we have more of reduced ejection fraction, unlike what you see in the Western country. And more importantly, why I'm really trying to drive home this point of innovative strategies, because the in-hospital mortality, what we have seen, has been consistent around 7%. If you take it in the perspective of an acute coronary syndrome, like let's say the STEMI, world over, we would say 2 to 4% is an accepted mortality. And in fact, I've been part of the Global Heart Attack Treatment Initiative, the ACC. Our last 3 years has been 2.99%. So what I'm trying to drive home the point is these are extremely high-risk patients and they behave worse than cancer. Because when we did a review, in fact, this article we have actually published recently, when we looked at in Asia, you find the diagrams on the left-hand side. China has a much lower rate, but then people could argue that there are a variety of reasons why, because they're underreporting in many things. But then in India, this is the Trivandrum Heart Failure Registry way back to what we currently seen. This is what it is, even worse than some other Asian countries, what we have nearby. And not only that, you follow them over a period of 1 year. And what we see today is about what is 30% mortality at 1 year has just come down to 20%. But then this again is worse than some forms of cancer. So I think it's time that we really rise up to the occasion and do something about it. And if you compare with the global statistics, look at China, India, US, we are phenomenally doing badly here. And then, well, at the end of 1 year, again, the mortality remains the same, but again, very high, which warrants some kind of an intervention. And when we actually did this study, we found that, we were talking about what things you could do to prevent this mortality, and that is typically the guideline-directed medical therapy. I would always tell my fellows there are 4, A, B, C, and D. A is the angiotensin receptor inhibitor, or the ACE inhibitor, or ARBs, or the modern one, the ARNI. B is the beta blocker. C is the short form for the cortical receptor antagonist. And D, for easy to remember, is a DAPA. The EMPA is also part of it. But then what I'm trying to say is when you look at all these therapies, we find that beta blockers perhaps important over a period of time. Even the last few years, we still really lag behind the Western statistics. And the wonder drug, which really brings down mortality, what is ARNI? It's a dismal 2.6% initially. Now it's just come up to 6.69%. So I think we really need to understand that there is a lot of problems in our country. Diabetes, a lot of comorbid conditions, chronic kidney disease, AF, very high mortality. Unfortunately, we do not have a data on SGLT2 inhibitors, and it's time that we really do something about it. So that's what actually people all over the world, they also looked at the evolution heart failure trial. They also found that it's extremely difficult for patients to be on the DAPA and the neomolecules, and the discontinuation rates are very, very high. We were talking about the fundamental four pillars of therapy, the RNA, the beta blockers, MR and SGLT2, A, B, C, D, which I just mentioned about. Of course, not to mention, forget about the diuretics, because decongestive therapy is also very important. And what's important for physicians to understand is, if you look at this graph, what you see on the left hand side, in fact, this is a mortality benefit. If your patient is on all four drugs like the RNA, the beta blockers, MR and SGL2, their mortality is probably the least. And that is irrespective of the age, whether you are 60 years, 70, 80 or 90. In fact, if you add all these four drugs, you get an extra 8 years of life in a 55-year-old individual, extra 33 years in an 80-year-old individual. That's the kind of effect this guideline-directed medical therapy has. And the question remains, what do you do? Why should we be starting this immediately? Why the rush? Why are we talking about it? Because, and that's where the hospitalization becomes very important. We today know that when you start these drugs, they are pretty safe even early. What was thought to be a contraindication beta blocker during our medical school days, today is one of the indicated drugs. So I think it's important that we start it early because the safety has been proven, significant benefit regardless of the background therapy, and opportunity also for close monitoring in the hospital. So that's why we need to really push it. And also, you just heard about Dr. Jayagopal talking about a strong HF, which I'll come to. And this, in fact, I keep quoting this article by Fauner way back in 2007. This came in. If you are able to start and initiate a therapy like a beta blocker, or let's say even an ACE inhibitor while in the hospital, the chance that these patients would continue would be very high, 93%, compared to if you are starting this as an outpatient. People do not adhere to a therapy which you start in the outpatient. Whereas if you start it as an inpatient, they know it's an important drug and they keep following that. And that's also the one important thing. And then more importantly, today we have the strong HF trial. In fact, this is a cardiac anesthetist. Mebasa is a cardiac anesthetist, had an opportunity to interact with this guy. In fact, this is one of the studies where they actually randomized in starting with this conventional therapy, slowed initiation, all the serial escalation of drugs, whereas the optimization initially itself start with half optimal dose, keep on increasing it in 2 weeks, and then what happens? And when they used this, they found that majority of the patients were able to attain the full dose or optimal dose of the target therapy at a much earlier stage. And not only that, they found that when they followed up these patients at 180 days, they had improvement in everything. For example, the respiratory rate, the peripheral edema, jugular venous pressure, and not only that, they also found that the events came down considerably. The high intensity care, they did extremely well. And that's perhaps one of the important reasons why you should initiate this while they are in the hospital. So that's why the acute hospitalization becomes an important point. And not only that, when this is one of the recent data from the Get Well registry, to the target dosage registry from 2016-2023, they found that they actually, out of the group, 82.2% were eligible for the cardiac therapy, but in reality, only about 15.3% really get it. So I think there is a lot to be done. And when you start analyzing why this does not happen, today we all know for sure, if you start your patients on guideline-directed therapy, the outcome is really better. But then it really does not happen because even in the Western countries, if you look at the target dosage of all the 4 drugs, it's just 1% in all the registries. Whether it's a CHAMP registry or the newer registries, it's just 1%. So in a country like India, you can understand how dismal it would be. There is a suboptimal discharge planning, there is a non-adherence, in fact, a lot of inertia and delays in seeking medical attention, many things, thus creating a need for a heart failure program. And also, today we know that there are ways to look at it. If you have a checklist while they're in the hospital, have a scoring just like what has been mentioned. Somebody is interested, they can go to this. And what the scoring would be acceptable would be more than 3 to 4 or more than 5. And this is one way of looking at it. And we also have seen that if you have a team which takes care of your patients, for example, a heart failure specialist, a physician, a pharmacist, dietitian, nurses, this really works wonders. And in fact, in the Western countries, they have found that the mortality comes down by about 10% just by using a team. And in a smaller context in Kerala, in 1,400 patients, we did this study for a few weeks actually. What we did was we used again the same model, used a heart failure nurse, and then we just followed up this patient. And when they tried looking at the weight gain and whether the questionnaire, whether they're taking these medicines, the prescription of guideline-directed medical therapy just at the end of 1 month started rising up. So there is a lot of things that you could do by having your team, and the outpatient following schedule when the follow-up also increased considerably. So this is some simple measure that you could do. Well, the same thing was seen in the titrate HF registry, 4,288 patients, 44% were on quadruple therapy, and when these were actually, there was a dedicated heart failure clinic to follow up these patients. So that is one of the innovative strategies that you could start in your clinic. Secondly, we also know that the team HF, which again, they also used a similar clinic, and they found that this guideline-directed therapy jumped from 21 to 88%. And again, significant improvement in the NYHA class, improvement in the ejection fraction, reduction of the NT-proBNP, and also less of mitral regurgitation and better outcomes over a period of time. Well, there have been a lot of newer innovative strategies. For example, the Western world, they have enough finance to do all this. Digital technology, we still have a lot in our control. When you use a digital technology to follow patients again with the usual care, this has been found to really work wonders. I mean, these are things which have been proven, but again, on a larger scale, to implement this in a country, it is extremely difficult. And we also went one step. We thought another initiative was probably the use of too many pills. So one pill, if you could combine everything, the A, B, C, D, together and put in a polypill. In fact, we wanted the first pilot program to be done in our hospital in the world. In fact, this was funded by the Northeastern University of Chicago. Unfortunately, DCGI did not give us clearance. It's gone to Sri Lanka now. And the first paper is actually ready for publication. So there are a lot of new things which I'm not really going to dwell on. You decongest them better, start them on early drugs, and follow them up better. And when we looked at what is happening in the Asia Pacific region, I was fortunate enough to be part of this group. We did a survey out of which the majority came from India. In fact, you see that the majority of these surveys, and that too from tertiary hospitals in the cardiologists took part. And what we saw, the key aspects of the survey was lack of patient awareness, which was about 80%, which is no wonder at all. But more importantly, what is shocking for us is a poor physician awareness of the diagnosis and treatment, which was 72%. And that's why we are really talking about this. And echocardiography, people today rely on echocardiography as to key thing for a diagnosis. So we have a lot of innovative strategies where, we like the STEMI care, we would like the patient from the center to go to the periphery and interact with the physicians, GPs, the pharmacist again directly with the patient, the nurse with the patient and the healthcare workers and the primary health center and so on. And we all know that there are many things, there are many reasons why this does not happen. So we really have to look at the change in systems, those patient. But what we would like to focus today, and more importantly, what something which we really wanted to, Dr. Jay Shah was part of this program, is basically to improve the physician awareness. And that's because if you can start this at an early stage, you really prevent mortality. Well, when we looked into why this is not happening, maybe as I mentioned, the awareness amongst the physicians is less, but more importantly, there are a lot of challenges with the physician faces in his practice. Low blood pressure, you can't start them on any medicine. For example, worsening renal function, you used to scare an MRA or an ACE inhibitor. Concern for low blood pressure. So there are many low cardiac output states. So there are many things, and there are a lot of comorbid conditions which along come with this. For example, atrial fibrillation and chronic kidney disease, which again actually creates fear in the minds of the physicians. So I think there is a lot to be addressed. And when we look at let us say, there are a lot of guidelines coming out. In fact, the recent heart failure guidelines, if you look into it, that comes as a big document. Who has the time to really go through it? And every practicing physician who's busy in his outpatient, can he have a complicated algorithm to just refer to this? We find this to be really a futile attempt. And that's why we thought we should go one step further. This was a consensus which we took from about 40 top cardiologists in the country. And that's what our essence of this talk is about, simplifying communication for the physicians. What we call it is the Indian heart failure profiling wheel. And this is a very simple thing which will be delivered to every physician. Our hope is that this will reach the desk of every physician in the country. We have the heart failure reduced ejection fraction there. The primary thing is to relieve congestion, use a diuretic, and then you have the 4 pillars, A, B, C, D, which I had mentioned earlier. And then every condition that a physician sees is started out. What is seen in green is indicated. What is yellow should not be used. So whereas what is in red is a contraindication. So you think you have a patient, you have the various problems like the normal blood pressure, all 4 are indicated, hypertension, all 4. So it's sort of a checklist for the physician to see what would be appropriate for your given patient. Normal heart rate, you will have all that, whereas a low heart rate, you will not have a beta blocker, which is in red there. Again, more than everything, if the heart rate is more than 70, then you probably, despite these drugs, you will add an ibobradine. So every comorbid condition which the physician would see and manage would be really be addressed by this heart failure profiling wheel. And this is what we thought about hyperkalemia. See, what you see in red, you cannot use an MRA. Whereas what is in green should really be prescribed. coronary artery disease, all 4 would be there. So this is a very simple thing which will be available on the physician desk for you to understand the patient better. Today we know that the heart failure 1% prevalence, it's such a significant number of patients. Only about 10,000 qualified cardiologists, the country cannot really manage this heart failure problem. So until and unless it comes to the physician level, this cannot be tackled, and that is what we need to really want to project and spread. So we also went one step further. The physicians, it's not only the physicians, cardiology, when we looked at it, in fact, some of our patients, the guideline-directed medical therapy, you talk about ARB, we still see a lot of telmisartan prescription, which is very sad. The only ones are either losartan, valsartan, or candesartan. So we know that there is still a gap amongst the cardiologists. The same thing holds good there, but we have gone one step further, because for the cardiologists, they may have to really look at patients. It's not just a heart rate. Sometimes you have to go into depths, find whether they have a left bundle branch block. The CRT is a new therapy which will really reverse this problem, and sometimes some of these patients do well. So this is actually meant for the cardiologists, and this again is going to be circulated for all the cardiologists in the country. So again, we have something in store for the heart failure for the preserved ejection fraction. Today, we know there is the only guideline-directed approved drug is an SGLT2, but there are a lot of newer drugs coming up. For example, you have the GLP agonist, the Finrenon. You must have heard about it. It's just got the initial trials cleared. So I think there is something really interesting and something really encouraging that we see in this context of heart failure preserved ejection fraction. But then again, these are the group of patients which should really go to the physicians, because this is a disease of comorbidity, and you probably at this point of time, you can only improve the quality of time for these physicians. So I think this is a new thing, which is a new innovative approach. In fact, I'm really thankful for all the 40 people who really took part in this deliberation over a few days to really put this into the right perspective. And this, we hopefully think will take the physicians to a better understanding of our heart failure program, and also take them one step further in the management of heart failure. So this is what it would really look like. You will have this distributed in your, and I was also fortunate that one of the major industrial partners, Sun Pharma, really helped us in pushing this further, this cause further. So I think the final thoughts before I end is that I need to emphasize again that heart failure, we are going through an epidemic, and this is a very dangerous thing for the country. The outcome is worse than some forms of cancer. But then what was really a disease which could not be treated 3 decades ago, today at least has really 4 classes of drugs which could be employed and millions of lives saved. So I think it's important that we need to create awareness about GDMT, and that's the first task by using this model. And second, importantly, for the physicians, I think it's also a disease of comorbidities. A lot of people should be involved. It's always a team effort. And this, again, whatever has been mentioned here, it would be a really useful checklist for the physicians. And thirdly, this is an easy available reference. I think you can, it's on your desktop. Any problem, for example, you have an atrial fibrillation, you have a chronic kidney disease, this is on your desktop. This is an easy reference card for you to really simplify the treatment algorithm. And this finally would turn out to be a single algorithm for the practicing physicians, in the hope that you have better hope for heart failure patients in the future. Thank you all for the kind attention.